Hello everyone, welcome to the Decabyte series. This is Decabyte number 5 and today we're going to talk about obstetric and gynecological emergencies part 1. So let's jump straight into it without wasting any further due time. Firstly, we'll talk about a little bit of anatomy of the uterus. The first part here is the fundus, which is the most important part. It is important because this is the point where implantation occurs, right? Implantation. Now we need to differentiate between two important points here, that is what is implantation and what is fertilization. Now, fertilization is where when a sperm fuses with the ova which is released from the ovum and they lead to the formation of a zygote. Now this takes place in the uterine tube, whereas implantation is the journey of this fertilized zygote which is going into the fundus of the uterus and get attached to the endometrium in the fundus of the uterus here most commonly, and that is called implantation. The second important part here is the body of the uterus, which is the largest part of the uterus. The third part is the cervix, which is the narrow part in this region which has two openings here, an internal and external, which are named as os. The fourth part is the most external part, which is the vagina. Now coming to the first topic today, which is ectopic pregnancy. Ectopic pregnancy is when the fertilized ovum, instead of implanting in the fundus, which is the normal location, implants anywhere else in the body, most commonly in the uterine tube at the ampulla. That is the meaning of ectopic pregnancy. So what are the risk factors for ectopic pregnancy? Anything which is going to delay the transfer of the fertilized ovum from the uterine tube to the fundus is a risk factor for ectopic pregnancy. For example, pelvic inflammatory disease. Now the cilia which are present in the uterine tube are responsible for pushing the fertilized ovum from the uterine tube into the fundus of the the fundus of the uterus. So when we have pelvic inflammatory disease, an ascending infection, it is going to go, those organisms are going to destroy the cilia, and therefore the fertilized ovum is going to implant in the uterine tube itself, and therefore it is a risk factor for ectopic pregnancy. A tubal surgery is going to scar the uterine tube by damaging the cilia, again produce an ectopic. An IUCD, most commonly a copper T, is going to form the barrier between the fundus of the endometrium of the fundus, and therefore prevent the normal implantation, leading to an ectopic. And of course, a person who is having a history of ectopic is at risk for developing further ectopics. What is the fate of ectopic pregnancy? An ectopic pregnancy, most commonly in the uterine tube, can come out into the abdominal cavity. This is called extrusion, or it can spontaneously undergo involution, or it can rupture, leading to heavy bleeding through the vagina. The third one, or rupture, is the most dreaded complication. The clinical features are: the patient will have unilateral pain depending on which fallopian tube is involved. Patient will have amenorrhea because of course it is a pregnancy. Abnormal vaginal bleeding can occur during the first trimester for unknown reasons, and the patient can have shoulder tip pain provided this fertilized ovum or zygote goes into the abdominal cavity and grows, and it irritates the diaphragm innervated by phrenic nerve C345, which is going to have referred pain to the shoulder. If the patient has a rupture of the ectopic pregnancy, they can bleed and can lead to syncope or vasovagal episodes. What are the investigations? We do a UPT to find out if there is a pregnancy or not. Then we do an ultrasound scan. Most commonly we go for transabdominal scan, but the more sensitive method is a transvaginal scan, where we pass a probe through the cervix and vagina and look for in the uterus, and if we don't see anything in the uterus with a positive UPT, most probably it's an ectopic pregnancy. Then we do the rhesus status of the patient, and if the female is Rh negative, then we arrange for anti-D immunoglobulin. We do a serial beta HCG because beta HCG levels in normal pregnancies double every 48 hours in the first 48 hours. This does not happen in ectopic pregnancies. And finally, we do a coagulation profile because ectopic people are at high risk for developing disseminated intravascular coagulation. Finally, how do you manage? We put in 2 large IV cannulae, arrange for 6 units of blood, and start fluid resuscitation, which is the mainstay of the ED management. Then if the female is Rh negative, we arrange for anti-D immunoglobulin and refer to the gynecological department. But the definitive management for an unstable ectopic pregnancy is the OR, where salpingectomy or removal of the fallopian tube is done, whereas medical management for a stable patient is methotrexate. If you remember, methotrexate is an example of an anti-cancer drug whose function is to arrest the cell cycle and prevent the multiplication of cells, and of course we can also use it in a fetus because a growing fetus is nothing but multiplication of cells. I hope ectopic is clear. Let's move to the next topic, which is pelvic inflammatory disease. Pelvic inflammatory disease is nothing but an infection in the pelvic region, most commonly an ascending infection through the vestibule and the vagina, and on its way up to the fallopian tube or out into the abdominal cavity, it can cause infection and inflammation anywhere on its route. The most common cause in 90% of the cases is sexual, where chlamydia trachomatis and Neisseria gonorrhea are the most common organisms. 10% of the cases, the secondary to procedures such as IUD, E. coli and group B streptococcus constitute the causes. Finally, the clinical features are patient will have fever, of course, because it's an infection, lower abdominal pain. Discharge is important because it is one of the features of infection and inflammation, and most commonly this is pus through the vagina. And the patient can have dysareunia, which is nothing but pain during coitus or sexual intercourse. This is because when there is friction between the penis and the lining of the uterus, which is inflamed due to PID, and this friction can produce pain during coitus, leading to dyspareunia. Sometimes this can be too much and there can be a breakthrough bleed, which is the final clinical feature of PID. What investigations? We do a UPT to confirm the pregnancy or not. Then we take bloods because we are looking for an elevated TLC count. We are looking for an elevated ESR, which are signs of infection. We take up some endocervical swabs from the cervix looking for organisms, chlamydia and gonorrhea. And finally, we do a transvaginal ultrasound scan because we want to see if there is an abscess, a tubo-ovarian abscess inside the uterus, because our management will differ based on the presence of abscess. Finally, what is the management? If the patient is not so ill, we can outpatiently discharge him with 2 antibiotics, Oflox 400 mg twice a day and metronidazole 400 mg twice a day for a period of 14 days or 2 weeks. The reason we have Oflox is to cover the gram-positive and gram-negative organisms, and Metrogel because this covers the anaerobic organisms. If the patient is severely ill, IV antibiotics, ceftriaxone and doxycycline have to be started in the ER. If the patient is having any kind of tubo-ovarian abscess, then surgical drainage has to be done. And if the patient is not improving after giving the above antibiotics and the patient is having an in-place IUCD, intrauterine copper device, we need to remove that because that can act as a source of infection. Finally, we have to screen the sexual partners the patient has encountered in the last 6 months and send them to a genitourinary clinic, which probably doesn't happen in India. The next topic is emergency contraception. This is one of which we encounter on a day-to-day basis. Levonorgestrel is one thing we can do, and copper T is the second option we have. Each has its own advantages and disadvantages. Levonorgestrel, it is nothing but a synthetic form of estrogen whose function is to inhibit the ovulation on the 14th day, and therefore there is no ova, no fertilization, no zygote, no implantation. We should be giving it at a dose of 1.5 mg single dose up to 72 hours, that is 3 days after an unprotected sexual intercourse. You don't need any prescription if the female is greater than 16 years of age, and there is no limit as such. You can take 2 or 3 tablets also, provided you have vomitings. The bads are that the patient, this levonorgestrel has a high failure rate which is directly proportional to the time. Like for instance, if you take the levonorgestrel or the IPIL tablet on the 3rd day, you have a higher failure rate when compared to taking it earlier. If the patient is having vomitings within 2 hours, then you need to give a repeat dose or a new tablet. Since it is estrogen and estrogen is responsible for bleeding during the estrogenic phase of the menstrual cycle, you can sometimes have mild bleeding or spotting at the vagina. Contraindications are liver disease, migraine and pregnancy. The reason why we don't give levonorgestrel in liver disease is because liver metabolizes estrogen. We don't want to stress the liver in already a diseased liver. We don't give it during migraine because estrogen causes vasodilation, and vasodilation causes headache, and therefore we don't want to increase the headache in patient with already having migraine. We don't give it in pregnancy because estrogen predisposes the patient to thrombosis, and a pregnant patient already has a lot of estrogen and is at risk for DVT and thrombosis. We don't want to put the patient at increased risk of thrombosis. Next, we have copper T. Copper T has an advantage of long-term contraception when compared to levonorgestrel. It can be effective up to 5 days. The way it acts is it inhibits implantation. Levonorgestrel inhibits fertilization. This inhibits implantation because it forms a barrier at the endometrium of the fundus, which is a normal site of implantation, and therefore no attachment. The bads are it is less easily available when compared to levonorgestrel. Only trained pros can put it, and abdominal pain during insertion. Because you have blocked the normal site of implantation, you are at risk of ectopics, and if you insert it in a wrong way, you can perforate or rupture the uterus. Now the next important topic is pregnancy bleeds. A pregnant patient bleeding during first trimester has chance of spontaneous miscarriage, ectopic or trophoblastic disease. During second trimester, placental causes are important with abruptio placenta and placenta previa, and during third trimester, the placental causes are again important with vasa previa and show of pregnancy as the differential diagnosis. Remember, ectopic pregnancy occurs only during the first trimester. Now, spontaneous miscarriage is going to be discussed today. The rest we will discuss in our next decabyte. So spontaneous miscarriage is nothing of conception less than 24 weeks or less than 6 months. That is the important thing here. Now, to understand spontaneous miscarriage, you have different types. You have threatened miscarriage, inevitable, incomplete and complete miscarriage. This classification is just based on a single thing, that is the cervical os. Is the cervical os open or closed? This is the cervical os. Now let's talk about threatened miscarriage. Threatened miscarriage is a condition where the cervical os is closed but not completely, so you have little bit of blood trickling out. This is called vaginal bleeding. So vaginal bleeding mild is present, but the products of conception have not been passed. That is a threatened miscarriage. Inevitable miscarriage is when the cervical os is open, therefore the vaginal bleeding is more, but the product of conception has not yet passed out, but inevitably they are going to pass out. That is why the name inevitable miscarriage. Incomplete miscarriage is when the product of conception has passed out but not completely, and complete miscarriage when the entire product of conception is outside with vaginal bleeding. That's a complete miscarriage. What are the clinical features? Of course, pain, vaginal bleeding. Cervical shock is when the product of conception, as you can see here, if it is stuck in the cervical os and there is excessive stimulation of the vagus nerve because of the product of conception, and that leads to hypotension, that is called as cervical shock. Sorry for the spelling. You do a vaginal examination to see if the cervical os is open or closed. What are the investigations you do? You do a urine pregnancy test just to be sure if it is and sometimes you can have a positive beta HCG. That does not mean that the fetus is viable, because products of conception, it takes time for the serum beta HCG to fall down, or urine beta HCG. Then you do a urinary dipstick to find out if there is any UTI, and serum beta HCG, because serum beta HCG in miscarriages will progressively fall down. So serial beta HCGs. And cross match if there is bleeding, excess amount, and you do a transvaginal ultrasound scan to look at the process of conception. How do you manage? Fluid resuscitation is the mainstay with analgesia for the pain. You remove the products of conception if the patient is having cervical shock, and ergometrin is given when the patient is having increased amount of bleeding. This is because ergometrin or ergot alkaloids are vasoconstrictors, and we want to cause constriction of the blood vessels and therefore prevent the excess amount of blood loss. 500 micrograms intramuscular is the dose given, and then we refer to the gynecological team. I hope this Decabyte has helped you understand obstetrical emergencies in a better way, and I will see you in my next Decabyte with the second part of the obstetrical emergencies. Thank you for your time.